let's move forwards. Gil Roberts, the same nihilist that said to me, everybody that's going to live is going to live, everybody's going to die is going to die. He said something to me when I was young and impressionable. He said, it's heroic fantasy to assume that we can fix everything when you're in the wilderness. We graduate from medical school, do residency, we go out into the world, we can save the world. And there are times in the wilderness where you really have to either watch somebody die or simply accept that there's not much you can do. But he said you really need to be prepared to alleviate pain. So it's a good idea to go into the wilderness with good stuff for pain. I'm not going to go over in this short talk what you should bring. Certainly NSAIDs. I put designer NSAID because if you go to Costco and you buy, a gumball machine full of ibuprofen, that's a lot of pills. You're giving them industrial doses of ibuprofen. That's a handful, 3 or 4 times a day. So for patients that require chronic anti-inflammation, I'll often bring whatever designer NSAID I can steal that can be dosed QD. Usually those take longer to time of initial onset. So for just acute aches and sprains, ibuprofen or naproxen's good stuff, but some QD NSAID's a good idea. And then narcotics. And we'll talk about injectables if we have time at the end. There's all sorts of new stuff on the market now. These are military morphine injectors. They're kind of like EpiPens. And there's all sorts of stuff coming out. These are fentanyl buccal tablets called Fentora. I have not used these. I'm just curious. We don't have time to talk about this, but anybody use these? Have you had good luck, bad luck? People have overdosed on these, and I have friends that have tried these in wilderness settings and had trouble titrating effect. How about over here? Good luck, bad luck? Right. And the idea for an expedition, obviously, why are we talking about this? Because it's hard to start lines on expeditions. So, we're looking for the ideal administration, route of administration, which is just dissolving in the against the buccal membranes. Okay, we're going to talk quickly about antibiotics, and this was a guy with a necrotizing fasciitis in the Himalayas years ago, and I didn't have any clinical lab, and we had really limited medical system at this particular clinic, and we were doing these daily debridements. So I was thinking, okay, this could be polymicrobial, of course, could be clostridial. I know there are people that can differentiate based on their sense of smell, but I wasn't up to it. And I thought, what am I going to start this guy on? And we just had a few drugs. So I put him, I think, on Keflex, Cipro, and Flagyl. And I figured that ought to cover it. And the guy made it through. Long story I'm not going to talk about, but let's talk about the antibiotics. And instead of talking about which antibiotics to use, and this is the part of the talk, please don't get angry. If you're an ID person and you're going, well, that's not what I would bring, that's fine. This is just what I've brought over the years, and I'll tell you why. And then, if there's a drug you like better, that's fine. So I think in terms of organ systems, and the primary organ systems that are affected, in my experience, in the expedition environment, are respiratory. Everybody's coughing, upper, lower, all sorts of crud. Lots of GI stuff, and not uncommon to see soft tissues, cellulitis, wound infections, that kind of stuff. So, what do I bring? So, for respiratory, I like azithromycin. You might say it's not perfect, doesn't cover everything. In my mind, it's the perfect expedition drug. Most patients can take it. So if you bring something with penicillin, you've got a subset of patients that can't take on an expedition, so you have to carry 2 drugs. Most people can take macrolides. Low side effect profile, better than generic, so people aren't going to feel sick on it. You can carry just a few pills and offer them essentially a 12-day serum level of this antibiotic. And for immune-competent, community-acquired respiratory crud, it works pretty well. So great expedition drug. It's, and now you can get, generic azithromycin, so the problems of cost are not so big. I know what you're all thinking. Cost? I just steal it out of my sample cabinet. Now, for GI, I think somebody else is giving a talk, probably Eric, somebody, on diarrhea. Have you had a diarrhea talk here yet? No. Well, anyway, I'll just say this. In 2010, I think most people would recommend and agree that you need some kind of fluoroquinolone. You might say, well, wait a minute, why would I use old-fashioned second-generation Cipro when we live in a day and age with more current-generation fluoroquinolones, things like Levaquin? And that's going to be your call. Obviously, the higher up you go in generation, the greater the gram-positive coverage and ultimately even a little anaerobic coverage. But for diarrhea, Cipro is the old tried and true. I think there's something about targeted therapy versus shotgunning. I still bring Cipro. If you decide to bring Levaquin, one drug fits all, that's fine. Go for it. For soft tissue, back in the olden days, being a few years ago, I was still using primarily first-generation cephalosporins like cephalexin. But now, even in the wilderness, yes, even in the wilderness, it is not uncommon to see methicillin resistance. So you need to bring something. Some of you will bring Cleocin, some of you will bring Septra, some of you will bring other things, but you need to be thinking about methicillin resistance even in the expedition environment. If you want to start with a first-generation cephalosporin, I think that's fine, but be ready to treat with something that will cover methicillin resistance. And then lastly, and forgive me if you're any infectious disease people in here? Oh no. Would you mind leaving the room just for one moment? You can read Manson's Tropical Diseases and memorize it, the differential diagnosis for fevers of unknown origin in tropical environments, and there are 937 differentials. I made that number up. Or you can do what I do, which is somewhere in the bottom of your kit, just carry some doxycycline. And when I've got somebody that's getting sick and they have a fever and I'm not sure what it is, that's when I pull the old-fashioned doxycycline or some derivative of doxycycline out for things like rickettsia and mycoplasma and psittacosis and all these weird things that you read about in medical school that you usually don't see, spirochetes, leptospirosis, and you've got somebody that's starting to tank, you don't know what to do, you have no availability of a clinical workup, doxycycline's not a bad choice. Was that pretty much an ID fellowship in 10 seconds? How do you feel about doxy? So don't forget these things are expensive, so if you're stealing out of your sample cabinet, have mercy on your patients. Somebody's probably going to talk about diarrhea. For things like, I'll just mention that, I was a river guide for many years in the Sierras when I first started. People would say, "Can I drink the water?" And I'd always go, "Sure." And because they're not going to get hepatitis or some kind of dysenteric bacterial infection from Sierra water. If anything at all, they'll probably get nothing. But if they get anything, they're going to get a protozoal infection, typically Giardia. And they're going to, the incubation period is such that they're going to essentially start developing symptoms 2 weeks later. They're going to blame the restaurant they went to the night before, and I'm off the hook. But if you're on a long trip, you might want to carry something to cover Giardia. And there's a great drug called tinidazole. Maybe somebody else will talk about it, so I don't want to spend a lot of time. But it's related to metronidazole. Instead of taking 250 or 500 TID for 7 to 10 days, you take 2 grams, industrial dose of tinidazole, and you simply go to bed, sleep through your icky symptoms. It makes you queasy. We didn't learn that word in medical school, but it's the best word for how you feel when you're taking Flagyl. And so, 2-gram dose has better efficacy for treating protozoa than a week's worth of Flagyl. Great drug. Back in the olden days, it wasn't available in the U.S., so I had to always ask my friends that were going to Nepal, "Hey, can you bring me some tinidazole?" And they'd come back, "I got this stuff." Because it's so much better than Flagyl. But now it's available in the U.S., and most pharmacies don't have it in stock, but you can order it.